So thank you and good morning. If people are wondering why I chose this title, it's because we're going to cover a bit of the literature, but we're going to talk about some of the discussion that's been held at frontline clinical settings as we struggle to use these tests and go through various tribulations, if you will. So we have a new podium here, finally. The other one was falling over, so this is a real move forward. In terms of conflict of interest, I don't have any from the pharmaceutical industry for driving. If you ever hear any driving presentations, you have to make sure the person is not funded by the automotive insurance industry, as they might have a motive to keep more people off the road and would be very, might bias the research in some ways. So always ask for that type of conflict of interest statement when you're hearing a driving presentation. So the objectives, I'm going to take a step back and just highlight why fitness to drive assessments, screening and assessments are so complex. I'm not going to do a lot on it, but we're going to do a little bit on that. Then we're going to compare the pros and cons of the commonly promoted tests, the ones in the guidelines, the MMSC, the CLOC, the MOCA, Trails B, and then the CIMARD. And we'll talk about a practical approach, essentially a conversation that's being held in frontline clinical settings, and then I'll really look forward to hearing what other people in the audience have to say about how they employ these tests. So this is the problem. When you look from 2006 to 2026, what we project is that the number of collisions is really going to escalate in the older age group, and the number of fatalities and serious injuries will also escalate in that group. So we're going to have more older drivers on the road, and we're going to have more older drivers involved in accidents and more older drivers being admitted to hospital with major injuries. And that's because when older drivers are involved in a crash, they're 4 times more likely to be seriously injured than young drivers. Their treatment is very costly, very complex, and often very prolonged, and the recovery is often incomplete. It's interesting, the majority of crash-injured seniors were actually driving the vehicle. They were not the pedestrians or the passengers. And the majority of the crashes they were involved in were multi-vehicle crashes. And think of the most challenging maneuvers on the road. Left-hand turn, crossing oncoming traffic, and merging into traffic. Those tend to be really challenging maneuvers for many senior drivers, and those result in crashes. So that means it's not just a risk for the person, for the older driver, but it's a public health risk or a public safety risk. And that changes the threshold at which we operate. So in terms of why is this so complex, it's not age. People don't lose their driving ability just because of age. It's usually medical conditions or medications that are the main cause that can make even safe drivers unsafe. That can affect drivers of any age, but as people age, they start to accumulate more and more medical illnesses and more medications. So the probability of these factors being at play increases or escalates quite dramatically. It's not just whether you have a disease that's important. So it's not because you have mild Parkinson's or mild diabetes. It's the severity of the disease. Has the diabetes progressed to the point where it's very unstable with hypo or hyperglycemia? Is there end organ damage in terms of peripheral neuropathy, vision changes, cognitive changes? So it's severity or instability of the medical condition. In terms of medications, it's high doses or changing doses. So people do need time to acclimatize to many medications, so that they may need weeks to months, including antidepressants, antipsychotics, and other and cardiac medications. Their body has to get used to it, and beyond a certain point, they can't acclimatize anymore. They've passed a threshold. So when you look at this, it makes sense that we, the medical community, are in a really good place to recognize conditions and medications that could impact on fitness to drive. I think it's been overstated. You know, the public and the Ministry of Transportation think we can do it all, and we can't. We're an important part of the puzzle, very important part, but we cannot do it all. So looking at the list of medical conditions, this is a partial list. The 3 Ds would be in there: dementia, delirium, depression. So these are when it's severe, moderate to severe, poorly controlled, or changing rapidly: diabetes, vision, hearing, cardiac disease, stroke, Parkinson's, arthritis, sleep apnea. There are 2 types of medical conditions here. There are some that give you a stable or chronic persistent deficit. That would be something like dementia, vision, stroke. So every time you test the person, you can find the same deficits. There are others that are episodic. That would be cardiac, seizures, or diseases where people fluctuate, like Parkinson's or sleep apnea. So they might be good at one point in time when you test them, and then later on they're impaired. So you may or may not pick that up. Some of those conditions, such as cardiac conditions, the fitness to drive guidelines are built around not the testing per se, but the probability of incapacity over the next year. So it's more probability based rather than physical exam based. So there are two types of medical conditions here. And in terms of the medications, once again, it's dose changes and high doses that surpass a threshold that people can acclimatize to. So benzodiazepines, narcotics, the anticholinergics, tricyclic antidepressants, antipsychotics, the bladder medications, oxybutynin, Detrol, Gravol. In fact, there are hundreds of medications that are anticholinergic, and we're completely unaware of it. Pharmacists can create a list of medications that have anticholinergic properties. You can look on the web. There are cholinergic load scales, but most of us, as we're using the medications, we're really unaware that all of these medications have a cumulative anticholinergic effect. Antihistamine seizure medications, even if the seizure is well controlled, the medications themselves, the phenytoin, phenobarbital, I can't spell obviously, I'll blame it on spell check. Gabapentin, pregabalin, clobazam, all of these medications can affect cognition. The Parkinson's medications, Sinemet and the others, can affect alcohol, cannabis, etc. So there's a number of medications that can affect cognition. So it could be the condition, could be the medication, it could be both. So what you're getting is a sense of the real underlying complexity of what we're trying to assess with some of these tests. The medications, the medical conditions can affect people in various different ways. Physically, it can slow them down. They can be weak. From a sensory point of view, they can lose their vision. They can have difficulty feeling things with their hands, feeling the steering wheel, or with their feet, feeling the gas pedal, brake pedal, being able to differentiate the two. With peripheral neuropathy, spinal stenosis, and there have been crashes that have occurred in people who have those conditions. Cognition, we're going to flesh that one out a little bit because I'm going to delve into dementia in greater depth. You can have slow thinking, decreased attention, various different cognitive perceptual deficits, and emotional. People can have anxiety attacks and panic attacks. So this gives you a sense. Many medications, many disorders affecting people at many different levels. It can be compensated for, though. Behavior can compensate for some of these deficits, albeit to a limited degree. So this is Michon's hierarchical model of driving. I think Michon was in the military because the key terms are operational, tactical, and strategic. So at a strategic level, that is planning. Do you go out in the rain and snow? Do you go out in the dark? Or do you just drive when the weather is good, the lighting is good, the traffic is low? Tactical is what you do when you're in the car. Do you follow closely to other cars? Do you back off and give yourself a good distance? It's your driving style. And then operational is your instantaneous reactions. A lot of the medical conditions and medications I've talked about have their primary effect at the operational level. How quickly can you respond to emergencies? Can you identify them? But some of them might involve the tactical, strategic level if cognition is impaired. So if you make good strategic and tactical decisions, you can, to a certain degree, compensate for some of your physical disabilities. And we do see seniors do that a lot. That's probably a primary reason why senior drivers avoid a lot of collisions. They really plan their day and they drive carefully. Plus, they have a wealth of experience. So they make good judgments until they develop some cognitive disorders that overwhelm their ability to make those judgments. So when you look at this, really, it's a really complex situation. For anyone to expect a screening or assessment protocol to pick up or predict 100% of motor vehicle crashes, we don't call them accidents anymore, they're crashes, it's really an unrealistic goal. When we look at a lot of our testing, if we're testing for those stable, chronic, persistent disorders, not the episodic ones, we're testing the operational skills, maybe a bit of tactical, strategic, and cognitive testing. We're going to miss new illnesses. Someone could test well and then go out and become delirious the next day. We can miss fluctuating diseases. I really have difficulty with sleep apnea where people fluctuate, Parkinson's, delirium. The way people behave in a testing situation may be a little different than the way they behave in non-testing situation. You know, especially if they're on the road doing a driving test, they might behave themselves and not open the window and scream out at the other driver or speed or do things like that. So there is a certain artificial nature to the testing we do. We test intrinsic factors. We look at the person who's driving, the older driver. We cannot test extrinsic factors. The weather, the other drivers, the road conditions, the car malfunction. Some of this may just by chance come up during the on-road, but it's not something that can be routinely tested. Some of this can be incorporated into simulator testing, but simulator testing has a long way to go. So the bottom line is we can do a lot of good because we know a lot about medications, we know a lot about medical illnesses, but we really can't predict all of crashes. So that's really one take-home message. So when we're looking at how well our tools operate, we have to keep that in mind. And keep in mind, everyone who gets behind the wheel is at risk for crash. It never goes to 0%. So the goal of this talk and any upcoming talks is to see how can we improve not just the tests, but how we use the tests clinically. So let's focus on dementia because I know more about that. This is Hopkins' modeling study, and Hopkins predicted that in 2000 there were 34,000 people with dementia who were driving in Ontario. Shocking numbers, probably 40,000 now. That translates into 100,000 in Canada. So it's a big issue. You know, sometimes we might think, well, we care for a lot of people with dementia. Maybe we just have selection bias. No, this is really a huge societal issue that has to be dealt with appropriately. Because of this, consensus guidelines have been put out for driving and dementia, and they're very, very limited. They say people with moderate to severe dementia should not drive, and the Canadian Medical Association defines moderate dementia as loss of one activity of daily living or two instrumental activities of daily living due to cognition. Now, the evidence for that is really weak or almost non-existent, so that's opinion-based. It's very useful. It makes sense that driving is a super IADL, and if you're losing lower IADLs, you should at least be worried about the higher level ones. So there's really a fair amount of logic to that rule, but it needs to be studied in greater detail. It recommends individual assessment for those with mild dementia. So we're going to get into what does individual assessment mean. This is the meat of the talk. And how do we do this? And the gold standard is a comprehensive on-road. The comprehensive on-road is much more detailed than the ministry on-road. So the individualized assessment that's often recommended is use the MMSE, the clock drawing, the TrailsB. There's some new kids on the block, the MOCA, the CMARD, we'll talk about those also, but these tests are in the old guidelines. The problem is the guidelines say use these, they don't tell us how to use it. They don't provide any operating instructions. They don't tell you how would you respond to different scores, what cutoffs should you use, are there certain errors that should be automatic failures that someone who does this really shouldn't be on the road. So there isn't a lot of guidance in terms of how you use these tests. And we're going to talk about a little experience-based guidance. So that'll be what we lead up to in this talk. So one of the major battles we witness is the MOCA versus the MMSE. So this is the mighty MOCA Rhino that none of your patients can recognize. Right? This is the hippo, you know, and that's the humble Marshall Folstein. So he's still alive and doing well. So in terms of why can't people recognize the MOCA Rhino, the MOCA really had a few good validation tests, and validation of cognitive screens was part of my master's thesis, but I don't think it went through enough tests and was validated well enough before it was released. So that's why we have elements that don't work well. It was released too quickly, and you have to be careful not to fire out these tests before they're fully validated. Now we're seeing different versions of the MOCA. Unfortunately, those different versions, none of the validation research that was done before is relevant to those new versions. The MMSE, created by Marshall Folstein, he walked around in a psychiatric facility and he looked at young psychiatric male patients and developed a test. It wasn't built around the DSM criteria for dementia. It was just to look at cognitive impairment in young psychiatric patients, and then the test really took off. So its scientific grounding when it started was pretty weak, but there's been a lot of literature on it since then. It's missing key elements. So if you looked at the MMSE versus the MOCA, the MMSE is not a very sensitive test, meaning it will miss cases of mild dementia and mild cognitive impairments. So a higher false negative rate. It would rate people with MCI or mild dementia, many of them as being normal. The MOCA, on the other hand, has a great website, mocatest.org. If I give you any links here and you can't see them, don't worry. You shouldn't be copying them down anyways. Go to the rgpeo.com website, right-click onto the link and open the hyperlink, and you'll get straight to the website. So the MOCA has great sensitivity. It really picks up cases of mild dementia and mild cognitive impairment very well. So why don't we just use it all the time? For this reason, the MMSE has good specificity. It's not very likely to label people with normal cognition as being impaired. The MoCA does not have as good specificity. It can label some people who are normal as being cognitively impaired. It mislabels people, so that would be a false positive. So it's more sensitive. It picks up more mild disease, but it also mislabels normals, usually around the cutoffs, 25, 26, 27, in that zone. There's a red zone around the cutoffs. When you get further away from the cutoffs, you can be more certain it's a valid test. The MMSE is copyrighted, so all of you should be paying $1 every time you use the MMSE. The MoCA is copyrighted, but they don't charge for use. It's open access. And the MMSE has many limitations. It wasn't built around the DSM criteria. In particular, it doesn't test executive function. And executive function is an important driving skill. But it has a large body of supporting evidence. The MoCA has some supporting evidence, but when I look at the studies, I'm not impressed. The methodology of some of the studies is fairly weak. That being said, in my practice, I'm starting to shift more and more over to using the MoCA much more often than the MMSE less often. So I'm starting to become more comfortable with the MoCA. I think it's a good test. It just should have gone through a few more validation studies and refinement studies. The clock, I don't have any slides on the clock. The clock is another one that's recommended. It's self-explanatory, right? You draw a clock, draw the numbers in, and draw the arms in for 10 past 11. The problem is that there are maybe a dozen different scoring methods for the clock, and very few clinicians use them. Any validation studies that have been done with the clock have been done with formal scoring methods that clinicians don't use. So the scoring methods are not in widespread use. They're used more perhaps by high-level testers, occupational therapists, neuropsychologists, but not by frontline physicians. When you look at all of these tests, MMSE, clock drawing, and a number of other tests, we did a systematic review a few years back, and it's still true. None of the tests that have been recommended by the guidelines have been fully validated in dementia, in persons with dementia. So they don't have cutoffs that have been validated in dementia. So that's curious, because people will say, haven't there been publications that have recommended cutoffs for the Trails B? And there certainly have, and people in this room, including myself, have published those cutoffs for the Trails B. So part of scientific thinking is you should challenge your own thoughts and your own ideas from time to time to see if they stand up to scrutiny. So that's what we are doing. We are challenging ourselves to see if the recommendations we've made in our CME articles are truly valid. So what I'm going to present here is some of the work of Dr. Mananita Roy, our geriatric fellow, who's going to stand up and wave to everyone. There we go. But I won't give away all your work. Don't worry. We can still publish the article later on. This is part of what she presented at the Canadian Geriatric Society National Meeting in April 2011 regarding the Trail B. So as many of you or all of you know, this is the Trails A. Draw a line through the numbers in an increasing fashion. Pretty straightforward. And Trails B is going from number to letter, number to letter. This is not my Trails B, by the way. This is somebody else's. So what Trails B tests, it tests a few things. It tests focus, it tests executive function, it tests dual attention. Can you pay attention to two things at once that are static, not moving? When you're on the road, you have to have multiple levels of attention, not just dual. You're looking at 15, 20 things at once, and they're moving. So this is a really low-level test compared to driving, but it's still one of the best ones we have around. So a 180-second cutoff has been recommended in different articles, including some of our own. So where did this come from? If you look back, this came from some non-driving literature. Fall-Stewart in 92, Franzen in 96, and Tomba in 2004. I think the Tomba article is the best, so that's the one I'm going to dig into a little bit. And I think we're probably going to get some debate about this article from people in the audience, and that's okay. Debate's good. We'll learn from each other. So Tomba, who's actually from Ottawa, works at Carleton, published this article in 2004 in the Archives of Clinical Neuropsychology. And it presented normative data for Trails A and B in 911 community dwelling individuals, 18 to 89, so a big spread of ages. Now, what does normative data mean? People have different assumptions. When I talk to different people, they think it means different things. There are two general definitions that are employed. One, it's the data for all individuals, whether they have disease or don't have disease. It's your population-based data. The other definition, which I think this was trying to get at and that more people lean towards, is it's the data for people who are disease-free. So healthy individuals who don't have any disease affecting their score. So what's the natural score in human beings who don't have any diseases who are affecting this? And I think that's what Tomba was trying to get at. What Tomba saw, and I'm going to give you more of the information, was that the performance on trails A and B really decreased or worsened with increasing age and lower education. So as people got older, it took them longer and longer to do trails A and B, and they made more mistakes. So this gets into a really heated debate between different people in the field. Some people think we should have, and we can continue with the debate in the question session, some people think we should therefore have age-adjusted norms for when we use these tests to screen for driving problems. Other people say, no, older drivers don't get more time to stop a car. You don't use age-adjusted norms for that particular function. So that's a debate that does rage from time to time. The other debate that rages is just because someone's in, let's say they are an outlier in the normative data, does that really mean they're safe to drive? Not necessarily, many people would argue. So this is some of Tomba's data, but I've probably already stimulated some thinking in the audience, and some questions or challenges will be coming. That's good. So Tomba looked at a convenience sample. He recruited people from other studies, including the Canadian Study on Health and Aging. Some of them had been recruited to these studies a few years before. So they might have developed new illnesses and might have been put on new medications in the interim. They were willing to participate. They might have been more confident. There's always a selection bias for a lot of these studies. And they may not have been a representative sample. So the question is, if you define normative as people who are disease-free, perfectly healthy, is this truly a disease-free sample? The medical psychiatric histories were self-reported. As I said, there was a gap between when they were in some of the other studies and they were recruited into this, or the data was used for this. The medical history and diagnosis of absence of cognitive impairment might have therefore been out of date. They all had an MMSE of greater than 23, so people can have dementias, deliriums, depression with MMSE of 24, 25, and their GDS was less than 14. I have to look at that again. I have to make sure I didn't make a mistake there, because GDS less than 14 certainly doesn't rule out depression. But their mean GDS was quite low, 4.1. So that was the population. When I look at that, I really question, is this normative data? Is this a disease-free population? And I'm not terribly convinced that it is. I think it's a very good job. It's the best that anyone's done, but it's not perfect. This, I think, is a key slide that came out in Tomba's article. These are the means, or the arithmetic means for the Trails B. Trails B would be the dark squares according to age. And if you look, all of the means are under 180 seconds. Now, there is dispersion around the mean. We're going to talk about that. But this is probably where a lot of the recommendations for the 180-second cutoff come from. So I think there is some validity, maybe not enough, but there is some validity to thinking about 180 seconds as having some meaning, as it really does span all of the populations. And you see how the scores, it takes longer and longer to finish these tests as you get older, more so for the Trails B than the Trails A. As I said, there was dispersion around these mathematical means, and these are three groups. The top group is ages 75 to 79, middle group is ages 80 to 84, and lower group ages 85 to 89. So 1, 2, 3. And what you see, we'll go from one group to the other. What you see is pretty much everyone in the 75 to 79 group was 180 seconds or less. You know, maybe they were 9 seconds over, a few seconds over, but the cutoff worked really well here. Even the people in the 10th percentile, you know, were captured by that cutoff. When you get to the older age groups, you run into problems. If you look at the 80 to 84 group, you'll see there are some groups that are in the 200s, 227, 204, 209. But when you look at the numbers, the people in these cells, it's a very small number of people that scored in the 10th and 20th percentile. When you get into small cells, statistically, you start to have problems. The results may not be valid, they may be outliers. So statisticians always worry when they see small numbers in these little groups, in these little cells. So we have to be very careful. The other things to and down in the ages 85 to 89, you see some people went up to 317. That was probably a very small number of people. The overall N for the group was 16, but it was spread across these 10th percentiles, so maybe one person was at 317, 1 or 2 here. So these are true minorities, true outliers. And you see the very worst person was just over 5 minutes. So if you have someone who's taking 6, 7, 8 minutes, they would be worse than anyone in Tomba's study. So keep that in mind. So these are some of our conclusions, that it was a convenient sample. It was very well done, but it wasn't perfect. They may have had some people with hidden disease in there with medications that could impact on their function, and perhaps some of those people in those lower cells with the longer trails B did have some issues. The sample sizes were very small in some cells, and you have to be very cautious in interpreting those. All of the means were under 180 seconds, so I still think that is a cutoff of interest. Whether we have to go up or down a little bit is something research is going to have to tell us, but it is helpful. And even if these are true norms, we have to ask ourselves, just because you're within the normative data, if you're an outlier just within the cutoffs, or just outside the cutoffs or in the norms, does that mean you're safe to drive? Not necessarily so. No one has ever proven that. So that was a general study of Trails B and the general population. It wasn't a driving study. There have been a number of driving studies that Dr. Roy has been looking at, and we have an ongoing study looking at these. Over 30 studies. The majority, 2 out of 3 have a positive association. 1 out of 3 have a negative, or no, not a negative association, but no association. But keep in mind, a lot of these studies are small. They're 12 people, they're 15 people. When you have small studies, you have a high risk of false negative results. So that's why we do sample size calculations. And that's been one of the criticisms of the driving literature. Too many small studies that are all prone to false negative results. So probably some of the no association studies are just are not really valid because they were too small. A couple of cutoff scores come out of the literature, and we're looking at this in greater detail. Ball in 2006 found a cutoff of 140 seconds, double the risk for crash. Stapleton in 2003 found 180 seconds, double the risk for crash in the next year. When Stapleton looked at the year after that, the association was lost, so it might only predict driving over 1 year. And then Mazur looked at, in 98, Mazur from Montreal looked at errors. So if you have 3 or more errors, the chances of failing the on-road were 5 to 6 times higher. So there is some evidence for what has been suggested as cutoffs of 180 seconds and 3 or more errors. It's not strong, but it's not completely lacking in evidence. And then some people reported cutoffs, but we couldn't find any justification for those at all. So this gives you a sense of the depth of the evidence for the Trails B cutoffs. So some people will look at this and say, well, that means Trails B is useless. And that's pretty much an overstatement. There certainly is some evidence for the cutoffs, and as you get further and further away from cutoffs, like 180 seconds or 3 errors, as you get further away, you get out of the red zone. Red zone is, in my mind, an area where you could have false positives or false negatives, and that's right around the cutoffs for anything. Could be ferritin, could be PSAs. For any test, when you're near a cutoff, you can get false positives, false negatives. As you get further away, if the test is valid, you can become more and more confident that there's a problem. So if somebody really was well educated, it's not a language anxiety issue, it's not a mood issue, and they start scoring 10 minutes with 10 errors, you can be much more confident that this is not a false result. The other thing we have to keep in mind, and we're going to keep repeating this, is physicians and their teams are not responsible for determining fitness to drive. In Ontario, our job is to report any clinical findings that we encounter, not just here, it could be a sprained ankle, it could be anything, any clinical findings we encounter that could impact on driving, to forward that information to the ministry, and the ministry makes that decision. That being said, our ministry could probably put a little bit more thought into it. But if you look at the letter of the law, that is the letter of the law. So when you're assessing someone, ask yourself, is this, I'm not passing them or failing them, but is this a finding that could impact on driving? And if it is, physicians are responsible for forwarding that information. As I said, where to set cutoffs, I think, 3 minutes, 3 errors right now. There's some evidence for it. You have to be careful when you're close to that. As you get further away from that, you can be more confident. But I'm sure we're going to have some discussion about that at the end, because there are very strong feelings running in different directions around that. So in terms of The MOCA, I really don't know of any literature on the MOCA in driving. In terms of the CMARD, how many people here in the room have seen the CMARD or heard of the CMARD? So it's a new test that's come out of Alberta. I would recommend that you go on the internet and look up CMARD and try to look at the scoring system. And you can look at this. It looks at word list, immediate recall, delayed recall, number conversion. So you see a number, can you write it out? Looks at supermarket task. Can you name items that you can buy in the supermarket? So I'd probably get 0 on that because I'm not allowed in the stores anymore because I buy too much Fruit Loops, I think. So I wouldn't do well on that. I'll be honest with you, I don't use this test, and I'll explain why after, but I think it does show some promise. I don't really fully understand the scoring system. If you look at the bottom here, you'll see a total score of less than or equal to 30, high probability of failing an on-road driving assessment. 31 to 70, referral for driving assessment recommended, and greater than 70, low probability of failing. So those are the thresholds that they use. I really like that they trichotomize. They didn't just say there's 2 groups, but there are 3 groups, trichotomization. I think that's something we've recommended in our papers, and it's something Bonnie Dobbs has recommended, so it's a very good recommendation. The CMARD has only gone through has only published 1 validation study. So, I already criticized the MOCA for firing out into general practice way too early. And I have to level the same criticism here. There's some promise in the first validation study, but you really have to undergo multiple validation studies of these tests. You need to refine your questions. You need to move your cutoff scores around before you put these tests out for general use, widespread use. And I'm not confident that the CMARD has done that. I think they've taken some very good initial steps. There's some promise here, but more work needs to be done. And this is why I feel this way. Let's look at the cutoffs of 30 and 70 that they recommend. So for those who scored less than 30, so if you look at their screening, that predicts they would fail the on-road or high probability. 14% of them actually passed. So 14% of them were misclassified. If you look at those who scored 70 or more at the bottom, so 70 or more indicates the person has a high likelihood of passing the test. In fact, 16% failed the test, so they were mislabeled. So there's still a great deal of false positives and false negatives, around 15% for both, and I think that's still too high for me because if you followed this, you might not send some of these people on for testing who should be tested. The other problem is the middle zone here, where they score between 31 and 69. Those people are all supposed to go on for more on-road testing, and in fact that captured 50% of the people. So this really didn't trim down a lot of the referrals for on-road testing. Some of these people we would have already known without the CMARD don't need an on-road, they can't drive. So it shows promise. There's trichotomization, but the elements in the CMARD I think need to be refined, the weighting needs to be refined, and the cut points need to be moved around. So I think that's something we encourage the developers of the CMARD to keep doing. So it's not a test that I'm comfortable using yet. That being said, trichotomization was a strong point. The other thing you have to keep remembering is what I said, when you get away from the cut points, as you get further away, you can be more and more reliant on the test. So let's say someone scored, instead of just less than 30, they scored 5. As you're doing the test, as you're watching them answer, you can be more and more confident that there's probably a problem here that at the very least you need to investigate further. If they score, top marks on the test, then you can be more and more confident. The false positives and the false negatives will tend to occur around the 30 mark, around the 70 mark, in that red zone around the cutoff points. The future. So this is where we are right now. You're getting a sense of the strength of our tests and the weaknesses. CanDrive is a national study funded by CIHR. It's centered out of the University of Ottawa. If you want to look at the website, candrive.ca. Once again, any link in this presentation, especially the long ones you can't write out, just go to the presentation on the RGP website, right-click with your mouse, and open the hyperlink from the menu, and it'll take you right to the website. So they've been following 1,000 drivers for 5 years to derive new screening tests to assess for fitness to drive. So screening tests that determine who needs to go on for further testing. They're also looking at the old tests, the MMSC, clock, MOCA, trails, and CMARD to see if they can revalidate some of those or find better cutoffs. So that information is still coming. So that's sort of a sunrise to tell us there's more coming. This next section, I think, is the most important. This reflects conversations that have been held sort of in different clinics with physicians, nurses, occupational therapists, neuropsychologists. And it's really looking at, despite the limitations of these tests, how can we use these tests more intelligently? In everything we do in medicine, we have to use our tests intelligently, even blood tests. The blood test doesn't diagnose. We look at it, we interpret it in the context of the rest of the person's physical and medical history. So we can't just use these tests slavishly and say, here's a cutoff, here's a reaction. We have to use these more intelligently. I think this is starting the conversation. This conversation will continue. And if you don't do this, if you apply this slavishly and just look for a single cutoff, single reaction, the test will be inappropriately applied. Patients will suffer instead of being helped. So questions to ask yourself when you're applying these tests is, number one, are the results consistent with other evidence? So if you have a Trails B, MOCA, MMSC, a history from the family that are all pointing in the same direction, there are problems, the person's having trouble with IADLs, their cognition's worsening, they're getting speeding tickets, they're dangerous on the road. If you have vectors pointing in the same direction, you can be more confident that the test you've used is valid. If the test is an outlier, everything's pointing in, let's say, a positive direction. No, we don't see any problems with IADL. Mom's functioning as well as she did 20 years ago. The other tests are doing fairly well. This is an outlier. Then you have to question, is the problem with the test or the person? So you have to question yourself, and then you should go further. I would say, don't just negate it and say, oh, it's all the test. I think that's the type of person who undergoes more occupational therapy or neuropsychology testing, or perhaps an on-road. So I wouldn't just stop at that point unless you really have clear evidence that it's not a valid test. Make sure you're not dealing with confounding variables that invalidate the test. So language barrier, low education, performance anxiety. Every time this person did a test in school, they developed severe anxiety. They could never do tests at school. Sensory deficits. They really can't see the test well enough. They couldn't hear what you were saying. They couldn't hold the pen. So make sure you're not dealing with this, but don't use these as excuses. I remember having one family telling me, well, you know, Mom failed that test. She got about 10 minutes with 10 errors on the Trails B. She failed because she's German. I'm half German, and I said, you know, the letters are almost the same. You know, I don't really believe that. So I asked her, why don't you write out the letters for me? She could write out all the letters of the alphabet without stopping. Write out the numbers. She could write out all the numbers. So test the person's ability to write out letters, to write out numbers. So in that case, I think that would have been a real excuse. That wasn't reflective of her ability, and the test really matched some of the other history that we were getting in any case. Look at trajectory when you're looking at your actions. So Sean Marshall of Can Drive taught me this. If you expect the person to improve, they have resolving delirium, recent head injury, recent stroke, you might interpret the test, or you might act differently. You might say, don't drive for a few more months, I'm going to see you in follow-up, and then you could move on there. So if you expect them to improve, you should operate differently than if you expect them to be stable or decline. So stable would be a stable head injury, stable stroke. They're not improving or deteriorating at that point. Or if you're expecting them to decline, if they're deteriorating towards the threshold, they've just passed the threshold and they're right at the border, but they've been deteriorating for a year or 2 years, you really don't expect them to get better. So you might treat that very differently than you would someone you expect to improve. So that's an element you have to factor into your actions and your discussions with the patient and with the family. Understand your role. I mentioned this before. We do not determine fitness to drive. We are doing a history physical exam, and this is sort of part of the physical exam, a cognitive exam, to assess the patient, perhaps for other reasons, perhaps for driving. If you have a finding that could impact on driving that you think is a valid finding, given what I said before, then your job is to report that, or the physician's job is to report that to the Ministry of Transportation. And the Ministry of Transportation has to act. Now, as I said, our ministry does tend to act very quickly and sometimes unpredictably. So we do have physician groups who, involving geriatricians, geriatric psychiatrists, neurologists, family physicians who are working on different scenarios and how you would report this to the ministry and get a consistent response from the ministry. But our job is to report findings that could impact on driving. Use common sense. Sometimes the deficit is obvious. So the cartoon says, don't start looking for your glasses at 80 miles per hour. If you start doing this, you have a driving problem. If you do this during your driving test, you have a real problem. So sometimes it's obvious. Some people will say you cannot use a screening test to assess fitness to drive. I would argue that dichotomization, that complete distinction between screening and assessment tests is very artificial. Some screening tests provide enough information if the person does badly enough. If they just got a 5 on the MMSE and you think that's a valid test, that person probably shouldn't be on the road. At the very least, as I said, you have to report that to the ministry. If you have very dangerous behaviors, if you're hearing the person's crashing their car into things, I had this in one of my clinics. The person hit 2 people on separate occasions in the parking lot. Okay, so that's a serious driving problem. That's the kind of thing you have to report. Significant physical or functional impairments, really they cannot hold a steering wheel. Their arthritis is so bad or their neuropathy is so bad, they cannot turn their head. Now some of these physical impairments you can modify the car for, so that's another consideration. Understand cutoffs, and I think Bonnie Dobbs, the maker of the CMARD, really understands this very well. Often there are overlapping scores between normals, people who are normal on a given issue, and those who are impaired. So relying on one cutoff, dichotomizing, really doesn't work very well in a lot of situations. So on this side you see the 2 overlapping results. We can call this MMSE, MOCA, or whatever we want. We have people who are impaired, people who are not impaired, and you see the scores overlap, so there's a zone of confusion where you don't know where they are. A better approach is really to trichotomize. People who clearly have a score that's so bad they fail the test, people who just blew the test away and they pass, you have no concerns, and then the mid zone of people who need further assessment. Some people will argue with this, but you know what? We don't have the resources to test everyone at a high level, at OT neuropsychology level. We just don't. Family physicians see millions of people every year. You cannot refer hundreds of thousands of people or millions of people to neuropsychology and OT every year. You do have to make some, family physicians and other frontline clinic physicians do need to make some decisions. When you're looking at the test, the width of this zone is very important. I think for the CMARD it's too wide still. 50% of people are going on for on-road testing. That's a lot. So what CanDrive is going to be looking at is trichotomization, and which tests can you compress this reasonably so that you're strategically using your occupational therapy resources, your neuropsychology resources, and your on-road resources, and you're not overwhelming them with referrals to the point where the people who really need to be seen are not being seen in a timely manner. When you're applying trichotomization, you should ask yourself a few questions. Given the results of the and I learned this from Dr. Dalziel, but I've reworded it a little bit. Given the results of the cognitive test, would you get into the car with the patient driving? Would you let a loved one or the granddaughter into the car with the patient driving? Or the one I would add is, would you want to be crossing the street if the person's driving towards you? Or would you want your family member in front of them if they're driving towards you? So those questions help you get off the fence. And you'll end up answering, yes, I have no concerns. This person did really well. I'm not worried at all. I'm not sure. They need more testing. Or absolutely not. They're so impaired, I would never let my child walk in front of the car that they're driving. If you're saying that to yourself, you really should be acting on that, because we are all responsible for public safety, not just the patient safety. So putting it together. So this is the approach, the landing strip for the airplane. I just like the picture, that's why I put it up there. These tests do not stand alone. You don't have people walk in, you give them a Trails B and tell them you can't drive, you can drive. That's not the way these things should be approached. They should be part of a larger assessment. And a number of approaches have been published. If you go to the RGP website, rgpeo.com, you look at the health practitioners section. In that you look at resources, and in that you look at safety and security driving. You'll find the driving and dementia toolkit for healthcare professionals. And once again, this link here, you just go in the presentation itself on the RGP website, right-click hyperlink, or open hyperlink. So this was developed, and the development was led by Dr. Anna Bijewski here at the Ottawa Hospital. We're on, I can't recall which version of the toolkit, and now there's also a toolkit for persons with dementia and their families. And within this toolkit, Dr. Bill Dalziel's 10-step approach has been incorporated, and I think that the toolkit provides a large context, and Dr. Dalziel's 10-step approach provides a more focused context within which you use some of these tests. So I'd encourage you to look at the Dementia Driving Toolkit. I'm not going to walk you through all of this, but it looks at dementia type, functional impact, family concerns, visual, spatial, ability to operate a car, visual fields, drugs. Then it has Trails in B. You could insert many different tests into an approach like this. So part of your homework is to go and to the website and look at the Dementia Driving Toolkit and the 10-step approach. So the tests should be within the context of a larger approach. Last slide, more homework. So you didn't know you'd have homework when you came here today, but because it's like the end of school season, right? You shouldn't be getting any homework at this point. So look at the Dementia Driving Toolkit. Here's the link to go straight to the toolkit. Look at Dr. Dalziel's approach. The approach has been modified a bit in an article in Canadian Family Physician, 2010, volume 56, page 1123. Once again, you can go to this hyperlink. And you can also look at presentations at the Alzheimer Knowledge Exchange. And here's the hyperlink. They have dementia driving resources for healthcare practitioners. So use the tests intelligently. Ask yourself those questions. Keep working with all of us to refine the questions, refine the approach, improve the use of these tests, and use these tests within the context of a larger assessment. Thank you.